All right, welcome to another deep dive. You requested we take a closer look at emphysema, and you provided some excerpts from a medical learning document with a real patient case study, so that's exactly what we're going to do today.
Awesome. Looking forward to it.
Yeah, it's going to be like we're medical detectives or something, piecing together the clues.
Ooh, yeah, love it. It's a really cool way to see how diagnosis happens in real life.
Okay, so picture this.
All right.
Our patient is a woman in her late 60s. She's sitting up in bed, struggling to breathe. She's got an oxygen concentrator running.
Okay.
And her skin is thin with some noticeable scars, especially on her arms. And her hands, they tremble a little bit as she's talking.
Interesting. I mean, right off the bat, those details are kind of screaming chronic respiratory condition.
Okay.
You've got the oxygen concentrator, right? That points to pretty significant breathing difficulty. Thin skin and the scars, that could be a sign of long-term steroid use, which is something you see a lot in conditions like emphysema.
Mm.
And the tremors, those could be from meds or even just from low oxygen levels.
Wow, so we've got some initial theories already. What else did the doctors find during the exam?
Okay, so the document mentions something called tracheal tug. Basically, it's when the trachea gets pulled down with every breath because the lungs are hyperinflated and not letting air out properly.
Oh, okay, so the lungs are kind of stuck.
Yeah, exactly. And they also noted intercostal recession. That's when the spaces between your ribs kind of sink inwards when the patient's trying to breathe. Shows how hard the respiratory muscles are working.
Wow, so the exam's really pointing to the lungs not functioning the way they should. What about listening to her chest, with a stethoscope? What'd they hear?
Wheezes, which mean narrowed airways, and also crepitations.
Crepitations.
Yeah, those crackling sounds means air is moving through fluid or collapsed airways.
Oh.
In a patient with, potential emphysema, these findings are pretty important.
Right, so putting it all together, it really is looking more and more like emphysema, isn't it?
Definitely possible, but to confirm, you'd want to do a pulmonary function test called spirometry. Measures how fast a person can exhale. Really useful for diagnosing these obstructive lung diseases like emphysema.
So how does spirometry actually reveal, like, the secrets of the lungs?
Well, one of the key things they look at is something called the FEV1 FVC ratio. So FEV1 is the amount of air you can forcefully exhale in 1 second.
Okay.
And FEC is like the total amount of air you exhale after a full breath.
Okay.
A low ratio, that tells us there's difficulty getting air out of the lungs, which is like a hallmark of emphysema.
Makes sense. Now, I know COPD, which includes emphysema, is classified by severity. How does that work exactly?
It's based on that FEV1 value compared to what's predicted for someone your age, height, and sex.
Yeah.
So over 80%, mild, 50 to 80, moderate, 30 to 50 is severe, and
Yeah.
less than 30%, very severe.
Wow, less than 30% lung function. That's hard to imagine. So where do we go from here? What are the treatment options for someone with emphysema?
First, you got to address any reversible factors. And in most cases, that means smoking cessation. But, the damage that's already done to the lungs, sadly, that's irreversible.
Right.
So the focus shifts to managing the symptoms and trying to slow down the progression of the disease.
And what does that management look like? I know the material mentioned a bunch of different medications.
Yeah, so inhaled medications, those are like the cornerstone of emphysema treatment. Inhaled corticosteroids help reduce airway inflammation, and bronchodilators relax the muscles around the airways, making it easier to breathe.
Is there a certain way these medications are chosen for individual patients? Like, does it depend on their symptoms or
Absolutely. For example, someone who has a lot of exacerbations.
exacerbation?
Yeah, like periods of worsened symptoms. They might benefit from those inhaled corticosteroids. But someone who's, say, experiencing more immediate shortness of breath, a short-acting bronchodilator, that might be their best bet for quick relief.
Interesting. Are there any downsides or risks to be aware of with these medications?
Yeah, so long-term use of inhaled corticosteroids can actually increase the risk of pneumonia. So that's something doctors have to weigh carefully. It's always about finding that sweet spot between benefits and risks for each individual patient.
Right, finding that balance.
Mhm.
Makes sense. Okay, so the materials also mention this term. It sounded a little scary. Cor pulmonale. What is that? And should we be worried about our patient?
Cor pulmonale is basically right-sided heart failure that's caused by chronic lung disease. It happens when you have these persistently low oxygen levels and increased pressure in the pulmonary arteries. That puts a lot of strain on the right side of the heart.
So the heart's working overtime to compensate for the lung problems. Could this happen to anyone with emphysema?
Not necessarily. In this case, our patient, based on the exam findings, doesn't seem to have it. There are certain things doctors look for, like swelling in the legs or an elevated jugular venous pressure, that's the pressure in the veins of the neck.
Okay.
But it is a serious complication. It can develop in severe cases, especially when oxygen levels stay low for a long time.
This deep dive's really uncovering a lot of interconnected aspects of emphysema. So if someone does develop cor pulmonale, what can be done?
Well, the mainstay of treatment is long-term oxygen therapy. And I mean long-term. We're talking at least 16 hours a day. It's not just about relieving shortness of breath in the moment. It's about correcting that underlying chronic hypoxia.
Okay, that's the low oxygen levels, right?
Yeah, hypoxia. That's what leads to cor pulmonale in the first place.
So consistent oxygen therapy is key for preventing further heart damage. Makes you wonder, what are the other uses of oxygen therapy, and how do they differ from this long-term approach?
That's a great question, and it brings up a really important point about how oxygen is used in medicine. See, it's not always about, long-term correction of a chronic condition like cor pulmonale. Sometimes it's used for more immediate relief, like during an acute exacerbation of COPD symptoms
Right.
or in like emergency situations.
It's fascinating how the same therapy can be used in all these different ways depending on what's going on.
Yeah.
And it makes me curious about other therapies or interventions that might be out there for emphysema. The source material, I remember it mentioned surgical procedures like bulectomy and lung volume reduction surgery. Those sound pretty intense.
They are, and they're definitely not for everyone, but for those folks with severe emphysema who just aren't responding to other treatments, these procedures can offer some serious improvement. We're talking lung function, quality of life.
Wow.
Yeah.
Well, I'm definitely intrigued. Let's take a closer look at those surgical options and see how they work. But first, let's just take a minute to kind of recap what we've learned so far about emphysema itself.
Sounds good. Let's get our ducks in a row before we go diving into that surgical world. Okay, so just to recap, we've established that emphysema is a type of COPD, right? It's characterized by damage to those little air sacs in the lungs. Leads to difficulty breathing, especially when exhaling. Spirometry, that's crucial for diagnosis. And the severity, well, that's classified based on those FEV1 measurements we talked about.
Right.
Treatment usually involves those inhaled meds like the corticosteroids and bronchodilators. And in severe cases, you've got to bring in that long-term oxygen therapy to prevent those nasty complications like cor pulmonale.
That's a great summary. So you really got me curious about those surgical options. Was it bulectomy and lung volume reduction surgery?
Oh, yeah. Those are interesting ones.
What exactly are they, and how do they actually help someone with, severe emphysema?
Okay, so imagine a cluster of grapes, right? In emphysema, those tiny air sacs, the alveoli, they're like the grapes, but they get all damaged and lose their elasticity. Sometimes they even merge together, forming these big air pockets called bullae. They're like giant, useless grapes, just taking up space in the lung, compressing the healthy tissue.
So bulectomy is like surgically removing those giant
Yeah.
grapes, those bullae.
Exactly. By getting rid of those bullae, surgeons give that remaining healthy lung tissue more room to expand and work better, can lead to some improvement in lung capacity and make breathing easier.
It's like decluttering the lungs
Yeah,
to
exactly.
make them more efficient. What about that lung volume reduction surgery? What's the idea behind that one?
Okay, so lung volume reduction surgery, that targets the most damaged parts of the lungs. Usually the upper lobes, those tend to be hit the hardest in emphysema. By taking those areas out, the diaphragm, which is that main breathing muscle,
Wait.
it can actually work more efficiently. The remaining healthier lung tissue can then expand more fully.
So both procedures are aiming to improve function by removing the problem areas?
Yep.
But they're targeting different parts of the lungs. It's fascinating how surgery can actually reshape and optimize a vital organ like that.
It is.
These procedures sound pretty intense, though. Who are they typically recommended for?
You're right, they are major surgeries. So they're reserved for those folks with severe emphysema who meet very specific criteria. They've got to have those significant breathing problems despite, trying all the best medical management. And their lung damage has to be localized to certain areas to make the surgery even possible.
I can imagine that decision to go through with a procedure like that isn't taken lightly. Really shows how serious emphysema can be in some cases.
Absolutely.
It also makes me think about the patient we've been discussing. We know she's on oxygen,
Right.
but the source material also mentioned muscle wasting in her hands and scars on her arms.
Yeah.
What can those details tell us?
Those are interesting observations. They give us a glimpse into the kind of the broader impact of emphysema and its treatment. You see, Muscle wasting, especially in the hands, can be a sign of malnutrition, a common problem in people with severe COPD. Their bodies are working so hard to just breathe that they burn a ton of calories and have trouble maintaining a healthy weight.
So it's almost like their bodies are constantly in a state of, like, energy deficit because of all the effort it takes to breathe.
Exactly. And those scars on her arms, those probably tie back to that long-term steroid use we talked about.
Right, right.
Steroids, they're great at reducing inflammation, but they come with side effects. One of those is thinning of the skin, which can lead to easier bruising and scarring.
Yeah. It really highlights that tough balance between managing the symptoms of emphysema and dealing with the potential side effects of the treatments.
Definitely. Underscores the need for that personalized medicine approach, Tailoring those treatment plans to each individual person's needs and circumstances. Got to weigh those benefits against the risks.
Absolutely. It brings up a crucial question, though. What causes this whole cascade of events in the first place? What leads to someone developing emphysema?
Great question. We've been so focused on the nuts and bolts of the disease and how to treat it that we
Right.
haven't even touched on the root cause.
So what is the primary culprit behind emphysema?
In the vast majority of cases, it's smoking. The chemicals in cigarette smoke, they just wreak havoc in the lungs, trigger chronic inflammation, which leads to the destruction of those delicate air sacs and the loss of elasticity. And over time, that damage builds up and eventually shows up as those breathing difficulties that are so characteristic of emphysema.
So it's not just the smoke irritating the lungs.
Nope.
It's a whole process of, like, ongoing inflammation and destruction of lung tissue.
Yep. It's a slow, insidious process. Often takes years, even decades for the full effects to really become noticeable.
It really makes you realize how important prevention and early intervention are. Smoking isn't the only cause of emphysema, though, is it?
You're right, it's not. While smoking is public enemy number one, there are other factors that can contribute. Things like long-term exposure to secondhand smoke, air pollution, certain occupational hazards like coal dust or asbestos.
Hmm.
And there's also a rare genetic condition called alpha-1 antitrypsin deficiency that can make people prone to emphysema even if they don't smoke.
Alpha-1 antitrypsin deficiency, that's a mouthful. Can you tell us more about that?
Sure, so alpha-1 antitrypsin, it's a protein that protects the lungs from damage caused by inflammation. People with this deficiency, they just don't have enough of this protective protein. Makes their lungs much more vulnerable to developing emphysema at a younger age, and even with less exposure to those risk factors like smoking.
So it's like their lungs are missing a crucial defense mechanism.
Exactly.
Leaves them more susceptible to that damage. It really highlights how genetics and environmental factors can work together in the development of a disease.
Absolutely. And while we can't control our genes, we can make choices to limit our exposure to those environmental risks. Avoiding smoking, limiting exposure to air pollution, being mindful of those occupational hazards.
Right, taking those proactive steps to protect our lung health. Speaking of which, the source material mentioned this technique called the end-of-the-bed test that can reveal some telltale signs of emphysema. What's that all about?
Oh yeah, the end of the bed test. It's a simple but insightful technique. Doctors observe the patient from the foot of the bed, looking for visual clues that might suggest emphysema. Not a formal test with measurements or anything, more like gathering info through careful observation.
So what kind of clues are they looking for?
Well, things like a barrel-shaped chest, which happens when the lungs get all conically overinflated. They also pay attention to the patient's breathing pattern, looking for things like pursed lip breathing, a technique people with emphysema often use to help keep those airways open. And they check for cyanosis, that bluish discoloration of the skin and lips, which means there are low oxygen levels in the blood.
It's amazing how much you can tell just by observing someone. But those visual clues, they're really just the tip of the iceberg, right?
Absolutely.
There's a whole world of microscopic changes going on within the lungs that are contributing to emphysema.
You're exactly right. And understanding those microscopic changes, that's key to understanding how the disease progresses and the reasoning behind the different treatment approaches.
Okay, let's do it. Let's zoom in.
All right, let's dive deeper into those cellular and molecular events that drive the development of emphysema.
All right, so we've got the big picture of emphysema. Now the diagnosis, the severity, the treatments, all that.
Yeah.
But now I'm kind of curious to, like, zoom in, Like
Yeah.
the microscope, see what's actually happening at the cellular level in the lungs.
Ah, that's where things get really fascinating. Emphysema, it's not just about those air sacs losing their stretch. It's this whole intricate dance of inflammation, enzyme activity, and ultimately the breakdown of like the lung's very structure.
Okay, break that down for me. What's actually going on in the lungs of someone with emphysema?
Okay, so picture those tiny air sacs, the alveoli. That's where the magic happens, right? Oxygen in, carbon dioxide out. But in emphysema, these delicate little structures are under constant attack.
Hmm.
The inflammation, triggered by stuff like cigarette smoke, brings in these white blood cells. And those release enzymes like elastase. Elastase is supposed to break down harmful stuff.
Okay.
But in emphysema, it goes rogue and starts chomping on the elastin in the alveolar walls.
Elastin, that's
Mm.
what gives the lungs their ability to, like, stretch and recoil, right?
Bingo. And as elastin gets broken down, the air sacs, they lose their shape, they lose their ability to function, they can't get rid of air efficiently, which leads to that air trapping and hyperinflation we were talking about.
So it's like the lungs are slowly losing their springiness, becoming more and more like overinflated balloons.
Perfect analogy. And if this keeps going, those alveolar walls, they can actually rupture and fuse together. That's how you get those bigger air pockets, the bulo
Yeah.
that we talked about. Less surface area for gas exchange,
Mm.
even harder to breathe.
Wow. A vicious cycle. It really makes those surgical interventions like bulectomy and lung volume reduction surgery make more sense, you know? Trying to get rid of the worst areas, give the healthy tissue a chance.
Exactly. It's all about damage control and optimization. But hey, we can't forget about those other procedures you mentioned, the pneumothorax and VATS. Different, but important role in all this.
Right, those were related to the surgical scars in the patient's history. Remind me, what exactly is a pneumothorax? And how is it connected to emphysema?
Pneumothorax, that's basically a collapsed lung. Happens when air leaks into the space between the lung and the chest wall, the pleural space, puts pressure on the lung and poof,
Okay.
collapse.
Okay, and why is this more likely in someone with emphysema?
Because those damaged, weakened air sacs, more prone to rupturing, especially in severe cases. A rupture near the lung surface lets air escape into that pleural space. Pneumothorax.
Those fragile air sacs are just like ready to spring a leak. What's the treatment for a pneumothorax?
Depends on the size of the leak, severity of the collapse. Sometimes small ones resolve on their own, but bigger ones, you gotta intervene. One common approach is a chest drain, a tube through the chest wall to suck out the air and let the lung reinflate.
Ah, that explains those chest drain scars the patient had. What about VATS? Video-assisted thoracoscopic surgery. That's a mouthful.
It is. But it's actually a minimally invasive technique. Uses a tiny camera and special instruments, all inserted through small incisions in the chest. Surgeons can see and work inside without those big, open cuts.
Sounds a lot less invasive. How's VATS used with emphysema?
Can be used for a few things, but with emphysema, it's often for a procedure called pleurodesis.
Pleurodesis. Vaguely familiar.
It's done to prevent those recurring pneumothoraces, which can be a real problem with emphysema. Basically, the surgeon irritates the pleural space, making the lung stick to the chest wall. No more air leaks, no more collapses.
Creating a permanent seal to keep that lung inflated. That's pretty ingenious. It feels like we've explored every little bit of emphysema now, from the microscopic changes in those air sacs to the surgical stuff to manage it all.
We've covered a lot of ground, and all starting with that one patient's story. Amazing what you can learn when you observe, question, and just connect the dots.
It's been a fascinating deep dive. I feel like I've got a much better handle on this whole complex condition. Big thanks to our expert for walking us through this crazy world of emphysema.
My pleasure. Always love these chances to dig into how the body works and share the wonders of medical science.
And to our listener, thanks for joining us on this journey. Hope you found it informative and interesting. Remember, knowledge is power. The more we understand about our bodies and the stuff they go through, the better decisions we can make about our health. Until next time, stay curious and keep on diving deep.